Welcome to Didactic Residency Edition, your podcast resource to survive and thrive in your psych residency. I am Dr. O, and as of this recording, I'm a second-year resident in the National Capital Consortium Psychiatry Residency Program. However, make no mistake, I do not speak for this program, nor do I speak for the Department of Defense, the federal government, or anyone else for that matter. What I say is my opinion, and I reserve the right to be wrong, so trust me at your own risk. It's a risk some are willing to take. References and recommended readings can be found at the end of the show transcript located at didactic.buzzsprout.com. Before I get started here, I want to turn you on to another resource out there for psych residents and med students. It's called Bullet Psych, and it's located at www.bulletpsych.com. And it gives you the option of signing up for a free daily email, which has content in bite-sized chunks to learn about, psychiatric disorders. It's created by a fellow residency colleague of mine, Dr. Marcus Hunt. And for those of you like me who tend to fall asleep after reading about 3 paragraphs, it may be just the thing for you. It is concise, well organized, and somehow still manages to give you a good, thorough treatment of its subject. So try Googling Bullet Psych and see where it takes you. By the way, Dr. Hunt is not paying me to say this. I do it of my own free will and admiration. Now, getting back to my meager attempts to impart knowledge, my last 3 episodes focused on classical cases of obsessive compulsive disorder, but the DSM-5 has included a few other related diagnoses in the same chapter, including body dysmorphic disorder, or BDD, hoarding disorder, trichotillomania, and excoriation disorder. Each of these have distinct obsessional components and compulsions, age of onset, degree of insight, and chronic course. Hence, they get their own diagnostic category. Something else I failed to give sufficient attention to in previous episodes is the presence of tics in patients with OCD. Nearly a third of patients diagnosed with OCD will have comorbid tics at least some point during their life. It's an interesting finding that points to a common pathway shared between OCD and at least some kinds of tics. So it's good to screen patients with OCD for tics and patients with tics for OCD. Also, I want to highlight the rates of suicidal ideation and suicide attempt among patients with obsessive compulsive related disorders. The rates of suicide attempts can be as high as 1 in 10. And comorbid disorders can greatly increase that risk, so please don't fail to do a thorough risk assessment for your OCD patients. Now let's start reviewing the rest of the OCD chapter. In body dysmorphic disorder, BDD, patients obsess over what they perceive to be flaws in their appearance. Other people are not even likely to notice these flaws or would characterize them as minor. But these patients are compelled to do something about the flaw, like excessive grooming or trying to cover it up or hide it. They could even have surgery to fix it. So they may do these things, but in the absence of correcting or hiding behaviors, they may also instead just spend ridiculous amounts of time in mental gymnastics comparing themselves to other people or to some ideal of perfection that they can never reach. Now, most humans have identified deficiencies in their own appearance. I mean, I have many, to include my annoyingly asymmetric ear placement that makes my glasses sit crooked. There's a huge cosmetic and plastic surgery industry that takes advantage of our need to do something about our appearance. Now, I'm not going to have one ear cut off and put back on a little bit higher. Most of us, when we change our looks or cover something up, it's actually enhancing our social functioning and making us feel better about ourselves. But in body dysmorphic disorder, the sufferers are experiencing significant distress or dysfunction as a result of their obsession and compulsion. They spend excessive amounts of time trying to change or hide their appearance, or at least wishing they could do so. They may have had multiple surgeries or expensive cosmetic procedures. There are a lot of things we can complain about our appearance. So if you're going to diagnose someone with BDD and their main problem is their overall body shape or habitus, then be sure to rule out an eating disorder, which might better explain their symptoms. Wanting to change someone's appearance to look more like another gender is not body dysmorphic disorder. Patients with body dysmorphic disorder don't benefit from their changes in their appearance. They tend to be just as bad or even worse off after they make a change. But people who do gender transitions, they do benefit. Their transition is therapeutic. The DSM would also like providers who are diagnosing BDD to specify the level of insight that a patient appears to have regarding the veracity of their beliefs about themselves. Do they think that others would notice the deficiency? Do they really know how unreasonable their obsession is? And then, if their primary concern is whether they appear muscular enough, the DSM wants you to specify this as well. So imagine a bodybuilder who looks in the mirror and sees noodle arms in the place of his or her bulging biceps. Patients with BDD are highly unlikely to walk into your office. They are far more likely to have regular visits with their dermatologist or plastic surgeon. Treatment is similar across the OCD spectrum disorders, including BDD. So forming a strong alliance with your patient, specific cognitive behavioral therapies, and SSRIs are the primary starting points. SSRIs may be particularly helpful in the presence of comorbid depression, which is very common. Also, from a psychoeducational perspective, it's imperative to disclose to a BDD patient that attempts to change one's appearance with procedures or surgery rarely improves symptoms and may exacerbate them. The next disorder to discuss here is hoarding disorder. Hoarding disorder is an obsessional disorder that results in the accumulation of possessions that usually add little or no value to someone's life. So, someone with hoarding disorder overvalues what they have. They feel the need to keep it and will experience distress if required to part with it. In hoarding disorder, the rate of accumulation of stuff depends on two things: the rate of acquisition and the rate of disposition. So the rate of acquisition minus the rate of disposition equals the rate of accumulation. Just because someone has a hard time throwing things out doesn't mean they necessarily have piles of things laying around at home. To get a diagnosis of hoarding disorder, possessions need to clutter the living areas such that the areas can't be used for their intended purposes. That may help to explain why this disorder has a higher prevalence in those over the age of 55. I mean, for one, it's chronic, and so as people age, their numbers in the population have time to accumulate. And they've also had plenty of time to make piles and to be diagnosed. Also, the natural progression of this disorder is that it gradually worsens over time. So people over 55 are experiencing more obvious dysfunction than they did when they were 45 and their house was a mess, but still manageable. Just like with all DSM disorders, the appearance of hoarding disorder in a patient may be better explained by something else. So a neurocognitive impairment may result in someone who buys excessive amounts of things or the same thing over and over and over again and then never gets rid of it. But they're not necessarily hoarding. Someone with any kind of executive functioning difficulties, for example, those seen in like ADHD, may not be able to organize themselves well enough to manage their stuff, but they would not necessarily be opposed to help getting rid of it. Patients with hoarding disorder are also not super likely to self-refer to your office. So Public health officials will often be involved with the patient, and families might be concerned for their loved one's health and safety. Cognitive behavioral therapies focusing on a patient's symptoms and SSRIs remain the first line for this, as well as other obsessive compulsive spectrum disorders. Motivating the patient to participate in treatment may be a big challenge, and they also may need special skills training to kind of help them to organize their home better. The next two disorders, trichotillomania and excoriation disorder, are so similar that to discuss them separately, I could just discuss one of them and then record the word excoriation disorder over the word trichotillomania and replace the words hair pulling with skin picking and then be done with it. Both appear most commonly around puberty and have a high female to male ratio. Excoriation disorder female to male ratio is about 3 to 1, but trichotillomania is a lot higher. It's as high as 10 to 1. I don't know why that is, but it might have something to do with the fact that societal expectations for short hair in males and long hair in females make it just less convenient for males to play with their hair and pull it out. Also, if you notice hair loss in your patient due to hair pulling, then ask if they also pick their skin and do a skin exam, because these two disorders are highly comorbid. You should also be screening for both OCD and MDD as well in these patients. Trichotillomania is one of the coolest sounding names in the DSM. Typically, patients are adolescent females. The diagnosis is pretty straightforward. They must be pulling out their hair, and this has to result in hair loss. They also have had to try it a few times to stop doing this, and there has to be, of course, significant distress or dysfunction associated with it. As always, you should rule out substance use, things like cocaine or other medical conditions like pica that may better explain their symptoms, especially if you think they're eating their hair. Also, ask about postprandial fullness, abdominal pain, nausea, vomiting, anorexia, and weight loss. If these are present, then it's reasonable to get an abdominal plain films and refer to GI for a possible endoscopy, ultrasound, or CT scan. What you're looking for is another cool sounding word, trichobasor, or a massive hairball in their GI tract. If you want to know the sites where hair pulling is the most common, then just think about the sites where hair grows most dense and is also most accessible, like the scalp, eyebrows, and eyelashes. And then finally, the pubic area. I mean, this makes sense in humans. A chimp would have far more options, I guess. Excoriation disorder is similar but without hairballs. It's manifested by skin picking, most commonly in those exposed and convenient areas like the face and the extremities, and it needs to result in lesions, not just pinching. Places that are more often exposed, like the hands and fingers, are convenient sites. The patient must also have multiple unsuccessful attempts to stop doing this, and there must be significant distress or dysfunction associated with it. And then, as always, rule out substance use like stimulants or other medical conditions like scabies or eczema that might better explain their symptoms. Evidence-based specific treatments for hair pulling and skin picking disorders don't really exist. I mean, because these disorders were just considered manifestations of OCD for so long, the first-line treatments for these disorders are the same as those for OCD, which I've discussed in detail in the last episode. So, stress seems to exacerbate these disorders, so psychotherapies focusing on alternative stress management strategies may help reduce the symptom burden. Before I end my series on OCD and related disorders, I want to leave you with something important. Something you're not likely to forget. I was recently reading a 2021 article called When Self-Harm is About Preventing Harm, Emergency Management of Obsessive Compulsive Disorder and Associated Self-Harm by Palmonbini et al. In the BJ Psych Bulletin. They describe a patient who has compulsively harmed themselves in response to obsessions of contamination. And I'll quote the patient here. I can feel contamination under my skin that's hurting people, and I have been trying to get it out. I used to use soaps and bleaches, but they don't work. So now I use corrosive alkali to try to remove the contamination. I needed to go to the shop and buy more when the police stopped me. I'm scared the staff will get contaminated too, and I don't want them to touch me. I highly recommend you continue to read this article, and I'm not going to review it in its entirety here. Instead, I'm going to use it as a segue to discuss a phenomenon I saw occurring during this apparently never-ending COVID-19 pandemic. There are many out there who just, to some degree or other, really deny the pandemic even exists and aren't worried about anything. And then there are others, like those out there ready to cash in on people's excessive fears about the pandemic. All sorts of devices and concoctions were developed to sell to the public, reporting they could protect someone or their loved ones from COVID-19 contamination. Most of these are not new, but just rebranded. Things that purport to use like magnetic energies or UV light, homeopathic magic, or some secret blend of herbs, or even more caustic or toxic substances. I suspect most of these things do nothing at all, but some could be harmful. Some contain substances like bleach or iodine, or even pharmaceuticals like ivermectin. Others might give high doses of radiation that could later result in cancer. I wonder about both the developers and the consumers of these products. On social media, the developers are often portrayed as pandemic carpetbaggers ready to cash in on other people's suffering. And I expect many or most of them are, but maybe some of them have obsessions of contamination themselves and compulsions to develop these substances or devices to protect themselves and others. The consumers of these products are often portrayed too as like scientific ignoramuses or conspiracy theorists ready to grab on to any sort of new QAnon or anti-establishment or prophetic source of information. Many, or even most of them, may actually be suffering from mental illness, either a delusional disorder or an obsessive compulsive disorder. Some may think, I know this stuff probably doesn't work, but I just can't stop myself from using it. What I'm trying to sell you here is that, yes, these products are repugnant, and yes, we need to do better to insist there's an accountability system to deal with their producers and their advertisers and the people who profit from them, like Facebook. But at the core of many of these products may be a level of mental dysfunction that's really not well understood. And we need to be careful that we're not simply stigmatizing and punishing the mentally ill. In my most recent episodes, I reviewed the identification and diagnosis of obsessive and compulsive related disorders and their treatments, which really lacked much specificity and needs a lot more development. I hope I've also inspired the listeners to have more sympathy for these patients and the broad levels of dysfunction they may experience, including, potentially, harming themselves to prevent harm to others. I am Dr. O, and this has been an episode of Didactic, Residency Edition.